on your exams. So you're going to see the question, read it, pick your answer, feel secure in it. If you don't feel secure in it, you feel some other type of way about it, that's that, and then you'll move forward. Right? So no spinning the block in PT anymore, right? We don't spin the block in life, so we're not going to spin the block in PT. We're just going to move forward. So you won't be able to go back on your exams. Also, you guys' exams will be 90 minutes. This is to get you guys used to going at a timed pace and also to prepare you for your NAPLEX exam. Now, this is not the exact timing for the NAPLEX exam. You have a little bit more wiggle room, but you guys have 90 minutes, same amount, 50 questions. Those are the major changes happening to your assessments. Everything else is the same. You guys have your integrated lectures that are the same, your disease state topics that are the same. I think you guys are the last group that still has like top 200. So yeah, those are only changes. And if you guys have any questions about like PT, overarchingly, anything involving PT, want to learn more about how we make PT and everything, you guys know where my office is. My whiteboard will be up to date this year, and that's a goal for me. So you guys will be able to look at it. Please do not look at my circle. That's never going to be up to date. But my whiteboard will be. All right. Let's take it to you guys.
Oh, but I'm just making sure, does anyone have any questions about what Dr. Grigsby just covered?
Good to go.
Good to go. Love it.
That before the first exam too, just to reiterate, yeah, right.
Since we are changing the exam mode, would we have a practice that would not be scored so that we can get familiar with the process before the exam?
A practice exam?
Yeah, so that would not count, but at least we get used to the new method before the exam.
So I'll address a little bit of how we could maybe do this, but we do have sort of like an assessment type of thing before the exam, before the first exam. So perhaps that would be a good time to maybe test it out. But yeah, we'll get into that. Yes.
So is this new rule going to be for top 200 too, or this is just PT?
Yeah. So on Wednesday, we're some of the Wednesday folks. Just as a heads up, yes, for top 200 quizzes and for assessments, like wherever there's the exam soft component, backwards navigation will no longer be enabled. So it's all going to be you just take you focus on the question and then you keep it moving. And again, the intention is meant to favor you. Your gut instinct is usually what is correct. So hopefully you stick to whatever what you opt for, and then you keep it moving. This is how the NAPLEX is. So the goal is to just get you prepared for that. Okay. Any other questions?
Oh, okay.
Good. I turned it off. But
it's
yeah.
fine. It's fine. And because we know that this is like a very large transition for you guys, we'll be surveying to be like figuring out how you guys feel about this and basically what things we can do to help augment. So when we come in and we're like, hey, we have a survey about how you guys felt about your first exam in cardio, not being able to go back, the timing, everything, you guys can answer as honest as you would like. But that gives us enough information to know how it is impacting you all, because we don't know unless you guys tell us. But everyone may not have the time and availability or really the comfort to be able to come and tell us in person. So anonymous survey will be sent out, but you guys can kind of say how this is affecting you and everything. So we can make sure that we are taking care of your well-being as well as preparing you for what's next. All right. Well, that's all from me. I will see y'all later.
Cool.
Thank you, Dr. Griggs.
No problem. Thank you. All right. Slivers. Okie dokes. So this course syllabus, it's viewable to all of you. You should be able to pull it up via Canvas. And then just as far as the updates go with the PT course, and then also something new that is part of the course, the details of that will be added to the syllabus and then reposted. As in, I'll get into explaining something new that we'll be doing starting this semester. And then once we've implemented that and the details are worked out, the syllabus will have everything that you need to know about that particular addition and just the things that we're changing with the course. Okay, so moving right along, this stuff is pretty straightforward, just as far as, the details of the course. So again, this is cardiovascular disorders. Dr. Culhane and I will be the course coordinators. So we will essentially be leading a majority of the course. There will be other instructors involved. So you can see here, there's Dr. Hall and then Dr. Gonzalez, which some of you may have already met him and perhaps were taught by him, but he is actually a great addition. And so you'll get to, have learnings from him as well. Another instructor actually that I have yet to add, I didn't add, was Dr. Joshi. So she's also part of the course as well. And then, I keep on noticing like the details that I should point out. So the timings for Monday, Wednesday, Friday are 2:30 to 4:20. Tuesdays and Thursdays are 1:30 to 3:20. So just keeping in mind what day of the week it is, and PT will be according to that. Okay, moving right along. So these are the learning outcomes and learning objectives, which are as part of every PT course syllabus. So this is pretty straightforward. No major things to highlight from there. And if you want to look into anything specifically, again, you have the syllabus to refer to. As far as the student assessment, so just kind of like the breakdown of how grading for PT will go. So there will be 4 exams to correspond to the number of credit hours. It's a 4-credit course, so there will be 4 exams. And we'll get into the details of what each exam will include. And then there's a case application grade. So this is a new addition that we'll be doing starting this semester. All of your PT courses will have a case application grade. And depending on how many credits it is, the percentage of how much it weighs is going to vary. For this particular PT, it's 20% of your grade. Okay. And I'll highlight just kind of the key things to keep in mind with that. So that's what I was referring to at the beginning. We're changing that aspect. Your grade doesn't solely depend on exam grades. It also includes now this case application grade. All right. As for attendance, so as far as the attendance for case application days and obviously exam days, that is considered mandatory. In case you are unable to make it on any of those days, and again, we'll look at the dates for the schedule. If those dates don't seem to align with your availability or there's something that comes up, communication in advance, as always, as you all know, is ideal. So just letting us know as soon as you can. Advance notice would be helpful so that we can make the arrangements that are necessary to, have you take them or the exam or the case application. And then we will be recording every class lecture via Panopto. So that will be set up and it will automatically be uploaded into Canvas for your viewing. So that is something that both Dr. Culhane and I will make a conscious effort to do. So that way you can access it later. And then any questions so far with anything that has been covered? Okay, great. And then other things to highlight. So case application days, again, I will provide more detailed instructions on what the structure of these days will actually be, but there will essentially be a quiz that you take at the beginning of the session, at the beginning of class, followed by a case activity. And then after that, to wrap up our session, we'll have like a feedback and debriefing portion to the class. Okay. So I will indicate to you exactly how much time you have for the quiz, how much time you have for the case activity, and then how much time we'll dedicate to just an overall review of just the quiz and the case activity. And you will note per the schedule that there is a case application day leading up to each exam. So the idea is that this case application day will help you prepare optimally for the exam, particularly the clinical portion. But it'll be a great way for you to just make sure that you have mastered the concepts that you need to with everything that has been covered up until that point. And then also the intent behind having these days is to prep you for a course that's in the spring. Have any of you heard of Advanced PT? Yes. So Advanced PT is a course that involves basically case-based application assessments, and even like presentations that you do tied to it. So this in a way will just kind of give you a sense of what it is to look at a patient case, how to best approach it, the key things that you ought to identify, and like how you ought to optimally manage a particular disease state, or maybe even multiple disease states at once. So that's the idea behind it. Remediation policy, this is essentially the same as always. So any final grade that results in less than a 70% is subject to review by our committee of progressions. So that is something that, applies for every course. So that's standard. Moving right along. So this is the most important aspect of just the course, and, how you ought to organize your just everything for the course, and, the dates that you ought to mark on your calendars. So today being our first day, we're doing the syllabus review right now. And then from today until Wednesday, Dr. CULHANE will go over the science portion of hypertension. So he'll be covering that with you. And then followed by that, as you can see, it will be the clinical portion of hypertension taught by me. And then that will lead up to our first exam. So it's crazy. Our first exam is actually going to be next week. But the great thing is that it's only one disease state, right? It's only one thing that you have to, and you get a lot of it, a lot of days of it. So you'll be in good shape.
Some of you are experiencing hypertension right now, or tachycardia.
Yes, but no, we'll ensure that you're in good shape. I think it'll be good. I promise it'll be good. Ooh, it did the two thing. Let me see if I could switch it to. Whoa.
There we go.
Oh, I got rid of the, okay.
That's all right.
It's fine. Okay. Anyway, so that is just an overview of what to expect for the first exam. And then you can see here the purple ones, those are marked as case application days. So again, I will follow up with more instructions on what this will be looking like. So again, the general structure though that will follow is you will likely take a quiz. It's going to be up to 10 questions. You'll have some time to do those questions. And then that's what I was saying earlier to Kingsley's point on preparation for no backwards navigation on exams. The quiz can have that sort of a model where it's like you're not able to go backwards to your questions. We can do that. And then after you take that quiz, you'll do a case. The case will correspond to that quiz, okay? And the case activity, it will be an open book. You can look at whatever resources you need to in order to complete the questions tied to that case. And then after that, we'll go over everything together. Okay, so that's the general structure that you can expect for these days. Does anyone have any questions about that? Like what case application days will look like? Yes.
So the case application, we'll start off with the quiz, then do a case application, then we'll do some kind of survey too?
So quiz, anywhere from like 10 to 15 questions, followed by a case activity. And then followed by that will be like a debrief session. So we'll essentially go over the quiz and the case together to ensure that if you have any questions, then you ought to address them then. And if you have any points of clarification, we'll ensure that those are taken care of during that feedback debrief session time period. Okay. So that's what it'll look like. Any other questions? Yes.
So exam 2 on Tuesday, September 9, right?
Exam 2 is on the 11th. So please refer to this as your guide for dates, not Dr. Grigsby's email, because those dates are not the most up to date. That email was, again, as he mentioned, that was when they were initially mapping out all the PT exam dates. But the most up-to-date version is what you see on the syllabus here. So these are the dates that you should mark in your calendar. Now, if this changes, then we will alert you that, hey, like, you know, exam 2 or 3 or 4 has been moved around or anything. But as far as right now, in this moment, this is what you would go off of. Does that make sense? Any other questions? Okay, great. So again, more to come with your very first case application day. And then your first exam will be hypertension and hypertension only. Followed by that, as you can see, the topics that follow will be dyslipidemia, coronary artery disease, stable ischemic heart disease, and acute coronary syndromes. Seems like a lot, but again, we'll ensure that it is digestible and broken down in a way where you can, prepare accordingly. The in-course remediation days, so as you can see here, the syllabus includes days for you to complete that. So this is essentially time that's carved so that you have time to look at, your exam, if you would like to review it. For those who score less than a 70%, it is going to be required that you do make it to the in-course remediation sessions. And this will just ensure that, you take a look at whatever was missed, and we'll go from there. Another utility of in-course remediation is a way for you to just connect with either one of us to clarify any concepts that may be leading up to that particular exam. So for example, say on Wednesday, September 10th, you want to review your first exam, but if you want to also ensure that you're prepared for the second exam the following day, it's a good utility of, using that time. And again, we'll block off the class time for that day. So it's a Wednesday. So again, 2:30 to 4:20 will be available to attend to that. Any questions so far? Okay, great. And then this module, it goes until October 3rd. So that will be our last final day for the last exam. So I think I went over exam 2 topics. So followed by exam 2, we have heart failure and stroke. And then followed by that will be anticoagulation and arrhythmias. So those are the rest of the topics that will wrap up the PT module. Okay. And I think those are the key points key points to highlight. Dr. Culhane, anything to add or anything that I'm missing?
Yeah, so if you have accommodations, okay, for testing or other things, you need to make sure that we have a new director of inclusion and accessibility. That's Ms. Manal White. She's really nice. She's there to help you. You need to get those accommodations renewed for the semester, so you should go and see her. And then get those to Dr. Naeem and myself as soon as possible so we can sit down and go over those and make sure that we are, we know what you need so that we're able to plan ahead and make sure that happens for you, okay? If that's not something you've used in the past, then don't worry about that. But if it is, please make sure you get those to us as soon as possible so we can make arrangements for testing and things like that. Okay?
Awesome.
That's it.
Great. Thank you. Yep. Thank you.
Okay, so we're going to get started here. We've got about a little bit more than 2.5 days to go through some of the pharmacology of medications that are used to treat hypertension. Now, I sent you an email earlier in the summer, a couple weeks ago, about a blood pressure regulation lecture that I wanted you to listen to and make sure you are conversant in, okay? Because I will tell you, if you haven't done it yet, you need to get on top of that today. Because trying to understand how drugs work that are used to treat hypertension is a nightmare if you don't understand the systems that are in place to help your body to regulate blood pressure, okay? You've got to understand those systems. If you do, 98% of these drugs, all they do in terms of how they work is that they block things, okay? That's it. They're blocking components of blood pressure regulatory systems. We're going to talk about our renin-angiotensin-aldosterone system drugs today because they are one of your first groups of first-line agents that are used to treat hypertension, okay? I am not going to be able to cover in the time that I have allotted all of the drugs that we use to treat hypertension, but I am going to get through the first-line agents, which include Raas, your Raas agents. So those are your ACE inhibitors and your ARBs. You guys should be familiar with those from your top 200, right? Okay. We're going to talk about calcium channel blockers. That's another category of first-line agents that you'll use all the time to treat hypertension. And Dr. Naeem is going to talk to you about when to use those versus ACE inhibitors and ARBs and all that kind of stuff. And then finally, we're going to go through our diuretic agents, specifically hydrochlorothiazide and thiazide-like diuretics, like chlorthalidone, okay? Because, again, they're all first-line agents, okay? There are second-line agents, okay, that are used in special circumstances, okay? And they're second-line because of the clinical data that's been collected over the years. Beta blockers, okay, alpha blockers. These are drugs that used to be used extensively to treat hypertension, but as we studied them, we recognize that the clinical outcomes associated with using those drugs were not quite as good as when we used ACE inhibitors, ARBs, calcium channel blockers, and thiazide-like diuretics, okay? Thiazide and thiazide-like diuretics. So the clinical data drives, okay, the selection of agents used to treat the disease. It's more complicated than that, and Dr. Naeem is going to get into it, but if you have that basic understanding right now, you're going to be in good shape, okay? I also wanted to say something about the way the topics in the module are laid out, just so you understand why we're doing this first, right? Followed by hyperlipidemia or dyslipidemias, right? Then followed by coronary artery disease and heart failure. Because typically in most patients, this is kind of the order, not in everybody, but in a lot of patients, this is kind of the order of disease states that people develop as they get older that will ultimately lead to another type of cardiovascular disease. So for example, hypertension can show up in patients early on, or hyperlipidemia, or a combination of the two, right? And the combination of those two, okay, can promote the development of coronary artery disease or blockages in your artery. Okay? That can lead to a heart attack or ischemic heart condition. And that can lead to the next disease state, which we talk about, which is heart failure. Okay? And then we'll talk a little bit about anticoagulation and arrhythmias and things like that. So there's a kind of an order, a method to the madness here that I think is important to follow along with. I think another thing that I like about this module is that there's a lot of repetitive use of drugs in cardiovascular disease. Like, you're going to see ACEs and ARBs so whatever you learn here today, you're going to see it again and again and again until October 2nd or 3rd, whenever the module's over, okay? Very, very, and you'll see it in renal too, and probably in endocrine in a little bit to some degree. Same thing with calcium channel blockers, same thing with diuretics. Okay, so put your work in now, and later on, that work will pay off in dividend. Okay, all right. So let's take a look at the Raas agents here, and talk a little bit about how they work and what they do. Okay? So the first learning objective, I think, is critical, and this is something you should immediately start testing yourself on, because you know this, you've had it before. It's probably a little fuzzy in your brain, right? But you've got to know the different basic steps, right, of the Raas cascade, right? You've got to know that angiotensinogen, right, which is this peptide hormone, is circulating in your bloodstream. And renin, an enzyme which is released from the kidneys, will interact with that molecule and convert it to angiotensin 1, right? And then angiotensin 1 is converted by another enzyme called your angiotensin converting enzyme into angiotensin 2. Okay, that's pretty much the biochemical process of it. And then being able to talk about and describe some of the cardiovascular effects of angiotensin 2, like vasoconstriction, venoconstriction, aldosterone release, okay? Just to name some of them. There are kidney effects of angiotensin 2, okay? Because if you understand that, when I throw in a drug like an ACE inhibitor, right, it's super easy. You know the target is the angiotensin converting enzyme, and it stops the conversion of angiotensin 1 to angiotensin 2, right? If you know an angiotensin receptor blocker, or ARB, blocks receptors on blood vessels and the adrenal gland, right, that are activated by angiotensin 2, then you know how they work, right? Okay, so again, you know, I like this topic because it makes sense to me, and you can make kind of logical predictions about what's going to happen one way or the other if you understand how the system works. So start with that, okay? We're going to have some structure-activity relationships, some medicinal chemistry. I'm not going to stress this a whole lot just from a time perspective, but we are going to talk about some basic medicinal chemistry for these drugs, for ACE inhibitors and ARBs. I will tell you exactly what you need to know. Okay, I don't want there to be any question. You do not have to memorize drug structures. I will never ever ask you to do that because I think it's dumb. Okay. Number two, you know, there are things, you know, that you might have to do in order to determine the difference between one drug in a class and a similar drug in that class. How are they different from one another chemically? And how does that lead to slight differences in their dosing and their pharmacological mechanism of action? That's really the important part, okay? And explain how the Raas agents impact the Raas pathway and lower blood pressure. All right, so you got to know the Raas pathway first that I just described to you. And then, if you understand what angiotensin 2, which is the kind of end product of the Raas cascade, does, you'll be able to predict how ACE inhibitors work and ARBs work. You won't have to memorize it. You'll understand it, okay? Everybody got that? One other thing, too. This is not easy. If you're confused or if you need help, all right, who do you need to see to get on my calendar? Mrs. Litz, right? She's your best friend on this, okay? If you can't get an appointment with me during the day, I will do a Zoom appointment with you in the evening if you need to, okay? And I will have a review session for this as well, probably sometime over the weekend. Just make sure we're all on the same sheet of music. All right? So again, don't hesitate to reach out. And if you come in groups, that's even better. It saves me a lot of time because a lot of times everybody's got the same questions, right? All right, everybody got it? All right. All right, so this is your Raas cascade, okay? And it's a complicated overview of it. It contains a lot of details here, and I'm going to tell you which ones are important. So if you've got your tablets out or your laptops or whatever, let's make sure we know what we need to know here, okay? I divide this slide in half when I look at it, okay? On your left is really the kind of the Raas cascade that you're familiar with. You see it there, right? We have angiotensinogen, angiotensin 1, and angiotensin 2. That's your main cascade. You got to know that, all right? You have to know that. Circle it, star it, you got to know it. Okay? Over here, okay, is a related pathway that kind of does the opposite of the Raas cascade, okay? And this is called the kininogen pathway here, okay? And I'm going to talk just a little bit about this, okay? as it is associated with one of the #1 side effects of ACE inhibitors. Anybody remember from Top 200 what your top side effect is for ACE inhibitors? Cough, right? And there's also potassium issues we gotta watch out for, right? But cough. In order to understand why ACE inhibitors cause cough, I'm gonna explain this part of the pathway here to you. But you absolutely have to know this over here, all right? I'm gonna tell you, this is about 90% of it. This is like your foundation stuff. If you know this and understand it, you'll probably navigate most of my questions, outside of the medicinal chemistry questions associated with ACE inhibitors. Everybody got it? So again, we start off with angiotensinogen, which is converted to angiotensin 1 by the enzyme renin, right? Which is released from where? The kidneys, right? And angiotensin 1, again, which circulates through the body, will get converted to angiotensin 2 by ACE, right? Your angiotensin converting enzyme, okay? Now, that's easy to know. The next step is, what in the world does angiotensin 2 do with regards to blood pressure regulation, okay? This was in the video that I asked you to watch in the lecture, right? But to summarize, two major effects here. Vasoconstriction, okay? When I say vasoconstriction, what I mean is constriction of arteries, okay? Arteries. And when we constrict arteries, okay, what component of mean arterial pressure do we change? Remember, there's two components to mean arterial pressure, right? TPR and cardiac output, right? So which one will vasoconstriction change? Total peripheral resistance, okay? Right? Or systemic vascular resistance. That's a part of TPR, right? Okay? So constricting arteries makes it much harder for the blood to flow through the circulatory system, and it increases pressure. Okay? Everybody got that? If you can't remember that, just remember, right? If you've ever played with a garden, who's played with a garden hose when they were a kid? Like when you washing the car, right? You know, a hose outside, right? And especially one that didn't have like one of those fancy garden hose heads on it, right? And in order, you know, when the water comes out just like that, you can't squirt anybody with it, right? But what do? If you take your thumb and you put it over the end of the garden hose, you increase the resistance to flow, and now that water is shooting out of there. You could hose down your parents or your brother or sisters, right, or a friend, okay? But that's what resistance does to blood flow, okay? It increases pressure, right? The other effect of angiotensin 1 receptor activation by angiotensin 2 is aldosterone secretion. Okay? Now, aldosterone is a hormone that is released from the adrenal gland, right? And it's released typically, and this whole cascade is typically activated under circumstances where blood pressure is low, right? Because what does this system do? It increases blood pressure, right? Now, aldosterone, okay, increases sodium and water reabsorption in the kidneys. And that increases blood volume, and that increases blood pressure. Okay? Everybody got that? Vasoconstriction and aldosterone release. Your two major effects of your Raas system. Now, why is this important for hypertension? Well, first of all, we don't really know what causes hypertension in individuals, essential hypertension or primary hypertension. Dr. Naeem is going to talk a little bit about this. There's two types, right? Primary or essential hypertension and secondary hypertension, where there is an identifiable cause. Like, for example, a type of secondary hypertension is called pheochromocytoma, where you have a tumor on your kidney or on your adrenal gland that is hypersecreting catecholamines and causing your blood pressure to go way out. And again, you can treat that by removing the tumor, okay? With essential hypertension, we really don't know what causes it. We know that there's a genetic predisposition to it or a genetic component, and there are environmental factors. You know, how we, our lifestyle, right? Do we smoke, right? Do we eat fatty foods? Do we exercise, right? All those sorts of things certainly play a role in that. But one of the things that we think is going on and essential hypertension is that the RAS system activity is elevated above normal. And if you imagine this whole system working harder or at a higher level than it would in a normotensive patient, you could start to see why hypertension might occur in those people. And so these drugs are very, very effective in lowering blood pressure, okay, by inhibiting this particular system. Everybody got that? Now, over here in the boxes, 1, 2, and 3, we've got our 3 major classes of RAS agents. We've got our direct renin inhibitors that block renin. We've got our ACE inhibitors, which are our most common, right? And we've got our angiotensin receptor blockers, or for you hip young clinicians, ARBs, right? Okay, all right. So did I just use the word hip? I think I did. I'm so sorry. Okay. At any rate, all right. So these drugs, you can see, they all do the same thing. They just work in different parts of the cascade. Okay. So if you understand the cascade and where these drugs work, it's really easy to see how these things work. Okay. Now, over here, okay, we have the kininogen pathway, all right? And it's kind of similar to the RAS cascade. We have these different types of peptide hormones that are circulating and have effects on blood pressure. They actually lower blood pressure. And one of them is bradykinin. I want you to circle this one because this is the most important one. I don't care if you remember kininogen or kallikrein, but what I want you to remember is bradykinin, okay? It causes vasodilation, it decreases resistance, okay? Decreases blood pressure. So it's kind of working opposite to angiotensin 2, right? Okay, now, the reason I'm highlighting this is because what happens in some patients, but not all, okay, is that if they're taking an ACE inhibitor, and it's working great, it's lowering their blood pressure, everything's good, but some of these patients are going to be very sensitive to the buildup of bradykinin that occurs with ACE inhibitor use. Because look what ACE inhibitors do. Not only do they block the angiotensin converting enzyme, which is good, that's what we want them to do, but it also has a secondary effect. It blocks this enzyme over here called kinase 2. And if that's blocked, what happens to bradykinin levels? It increases, especially in the lungs. And so you start to get vasodilation of blood vessels in the lungs. Bradykinin is also an irritant, right? And so what do you think can happen then? If patients are very sensitive to that, it can cause that cough all the time, okay? So it's bradykinin buildup due to ACE inhibitor use that leads to the cough that's associated with ACE inhibitor use. Like I said, it doesn't happen, thankfully it doesn't happen for every patient, right? But it does happen in some. And it can be a reason why you might take them off of that, okay? Now let me ask you this question. I want everybody write everything down here. Would an angiotensin receptor blocker cause a cough through that mechanism? No. Is there a cough side effect associated with ARBs? No. And why? Exactly. It doesn't affect bradykinin. It works downstream, further downstream in this pathway. So again, Dr. Naeem's going to talk about if you have a patient that's doing well on an ACE inhibitor and they've developed a cough and they can't take their drug, okay. We have another alternative that works just as well, and that's your ARBs, okay? So we can still lower the blood pressure but not experience that cough, okay? I spent a lot of time on this because it is important, right? Who has questions? And I know it's awful hard. Yes, sir, I know, go ahead.
So, the kinase 2.
Yeah, kinase 2, yeah.
So,
It breaks down bradykinin. See what kinase 2 does here is it takes bradykinin and it destroys it, makes it inactive, right? And so an ACE inhibitor, if an ACE inhibitor can inhibit this enzyme, what happens to active bradykinin levels? They start to go up, and that's why you get it all. Okay? Who else has questions? Don't be embarrassed to ask questions here. I've been teaching this for almost 30 years, and I know this is not easy. Yes, sir.
Okay, I'm just curious. The hyperkalemia side effect,
Yeah.
is it as a side effect of the reabsorption?
Yes.
Okay.
So the hyperkalemia that we get here with ACE inhibitors has a lot to do with the effects that it has on aldosterone. And we'll get to that in a minute. Remember, aldosterone, when aldosterone is released, right, and it acts on the kidney, it helps your body to hold on to sodium, right, but get rid of what? Potassium, right? That's what normally happens. But what if we block sodium? The reverse happens, okay? Your body loses sodium, but holds on to potassium. And that's what causes the hyperkalemia. Okay? So I'm going to say that again because I can see people writing frantically here, right? Which is good. Okay? One of the other major side effects with ACE inhibitors or ARBs, with any of these ones here, is hyperkalemia. Okay? High potassium levels. Why does that happen? Okay? Well, if you understand the Raas cascade, you can understand why that happens. Remember, when the Raas cascade is normally active, right? Aldosterone is released from the adrenal gland, and that acts on your kidney and tells your kidney to hold on to sodium and get rid of potassium, right? That's what normally happens in all of us. But if we block aldosterone release from the adrenal gland with an ACE inhibitor or an ARB or even a direct renin inhibitor, and aldosterone levels go down, now your body's going to tend to get rid of sodium, but hold on to potassium, okay? And that can cause hyperkalemia in some patients. Not every patient, but it can. Okay, you have to monitor that. So again, you can understand side effects in a lot of cases, or mechanism of action of drugs if you understand this. Yes, sir.
Quick question related to the sensitivity of the patient.
Yep.
Is it more common to find a patient that's like sensitive to the bradykinin buildup, also be sensitive to ARB, like hyperkalemia?
Yeah, that's a good question. I will tell you that I don't think so. Okay, I mean, I like I said, I've been teaching with clinicians in this topic for a lot of decades. I've never heard that before. It's just something that tends, people will tolerate bradykinin differently. We're all kind of different that way biologically. So you might be able to tolerate a certain buildup of bradykinin in your lungs without getting a cough, but somebody else may not. Maybe their tissues are very sensitive or they've got something else going on. And there's no connection between that and hyperkalemia, okay? Again, I would imagine if you have someone with compromised renal function, right, then you may need to watch out for that potassium level, right? Because what happens when potassium levels go outside of normal range? Why is that bad?
Arrhythmias.
Arrhythmias. Life-threatening arrhythmias. That's bad, okay? Everybody got it? Yeah.
I think it was a stretch, but how does it relate to secondary hypertension?
In terms of what?
Like the whole system.
The whole system, yeah. So the question is, how could this potentially, the system, how could the system be related to secondary hypertension? So, I'm trying to think, a lot of drugs cause secondary hypertension. There's certain disease states that are associated with secondary hypertension. I don't know, I can't think of off the top of my head a diagnosable type of secondary hypertension that is associated with overactivity of the Raas cascade. Dr. Naeem's going to give you probably a list of those secondary so pay attention to that. But again, in some patients, and we don't do this, like when you come in and you're diagnosed with hypertension, we don't run a bunch of tests to see, is your Raas cascade overactive and things like that. No, we just start you on an ACE inhibitor. But they work because this is such an important part of blood pressure regulation. Okay, does that make sense? Good question. And the other thing I want you to understand too is that the Raas cascade's ability to change blood pressure in your body is fairly slow. All right, it's more of a slower process versus if a grizzly bear walks into the back of the room. Okay, all right. Now you've got us covered, right? Because the rest of us are running. You and Kingsley, you're taking up the rear position here, and you're going to protect us. I'm running for that door there, right? Okay? I'll try to remember to keep it open for the rest of you. But when that grizzly bear comes in, what happens to your fight or flight response? Oh yeah, your sympathetic nervous system goes right off the charts, right? What happens to your heart rate? What happens to your stroke volume? What happens to your cardiac output? What happens to your systemic vascular resistance? Increase, right? Because an increase in blood pressure will help to deliver oxygen and nutrients via the bloodstream to those muscles so that you can fight or flee. Okay? And Kingsley and Degmau, we thank you for your sacrifice. You'll be fighting. The rest of us are fleeing. Okay? All right, good. All right, great.
And hopefully,
What's that?
hopefully one person will remember we are here and come back to join us.
That's right. Well, here, and I'm going to tell you something. As a man who enjoys being in the wilderness and outdoor and backpacking and camping, I'll tell you one rule about grizzly bears. If you're with a group of people, the best way to protect yourself from grizzly bear attack is make sure you're not the slowest person in the group. Okay? As long as you're faster than everybody else, you're good to go. Okay? All right, good. That's Dr. Lee's wilderness advice for the day. All right. Moving on. All right, let's get into some med chem. I need everybody to refocus here. Okay? Focus, grasshoppers. Okay? As Mr. Miyagi used to say. All right. You guys are too young to remember Mr. Miyagi. I'm sorry. Okay. At any rate, Karate Kid, right? Classic movie. If you haven't seen it, you should see it. It's good. All right. So we're going to start with the ACE inhibitors. These are definitively our oldest class of drugs in the Raas category here. Okay. Everybody following me? And there are different chemical subclasses of ACE inhibitors. There are actually 3 of them. We're going to talk about all 3, okay, why they're different chemically from one another. But they all share a similar pharmacophoric structure. You guys remember what a pharmacophore is? Right? It's a chemical structure, general chemical structure that all drugs in the same class share. Right? Okay? Now, we've got a couple of things here. Every single ACE inhibitor you will look at today that I'll show you has this general pharmacophoric structure. We start over here to your right. We've got a nitrogen-containing ring. This is a pyrrole ring. Okay? Do you need to know that for the test? No, you don't. So don't sweat it. Don't get upset about it. Attached to the pyrrole ring is a carboxylic acid group. This part of the molecule actually is very important because it mimics the naturally occurring chemical structure of angiotensin 1. Okay? This is what fools your angiotensin converting enzyme into thinking that this drug is a naturally occurring substrate. All right? Again, that's FYI. I'm not going to test you on that, but I wanted you to understand that, right? Okay? On the other side, okay, we have a hydrocarbon chain here of various lengths, depending on what drug we're talking about. That's why that N number is there. That just means it could be 2 methyl groups, it could be 3, it could be 4, all right? But it varies from drug to drug, and then you have an aromatic ring over here on the other side, okay? But in the middle, you've got something called a zinc binding group. This is important, so you got to star that. In the catalytic region of your angiotensin converting enzyme is a zinc cation. This is very common in some types of peptidases or enzymes, okay? And this is the part of your ACE inhibitor that binds to that zinc cation in the enzyme's catalytic site. Everybody following me there? Okay, and there are 3 different types of zinc binding groups which define the different subclasses of your ACE inhibitors. Okay? So this part in the middle, the zinc binding group, is the part of the molecule that binds to the angiotensin converting enzyme. Everybody understand that? If you understand that, that's a good level to be at. Okay? The next level up in terms of complexity is that the reason it binds to that part of the enzyme is there's a zinc cation there in the enzyme. Okay? And so this part of the molecule will bind very nicely to that zinc cation and stick there. Pretty good. Okay? Using technical scientific terms. Pretty good. All right? Everybody got that? Questions? And there's my laser pointer. All right. So let's take a look at some of these drug molecules so we can point out these different parts here. Okay. All right. First type of ACE inhibitor we're going to talk about are your sulfhydryl containing ACE inhibitors. This is your first subcategory of ACE inhibitors. They're called sulfhydryl ACE inhibitors because their zinc binding group, which is right here, is a sulfhydryl group. This is the part of captopril that binds to the angiotensin converting enzyme. So you can circle that. You can see, you look over here. You see the pyrrole ring over here with the carboxylic acid attached to it? Like I told you before, there it is, okay? What this is missing actually is that other part. Okay, if I go back one slide, you see this part right here? Okay, the hydrocarbon chain in the aromatic ring. In captopril, that's not there. This is the oldest type of ACE inhibitor that we have. It was the first one that was commercially used. Okay? Now, what's the problem with captopril? Because we really don't use it very much anymore. There's a problem with it. It lowers blood pressure really, really good. But if you look at its dosing frequency, right? Anybody know what the dosing frequency for captopril is? What's that? 2 to 3 times a day. 2 to 3 times a day. Okay? Let me ask you this question. Do you think somebody with high blood pressure, okay, that can't feel their high blood pressure, right, that may not even want to take medication for their high blood pressure, do you think they're going to take a drug like this 2 or 3 times a day? No, compliance is terrible with this. All right? It does work really well to lower blood pressure, but because you got to take it multiple times a day, it's not a great drug. Now, the reason for that is, okay, this drug, when it's administered, all right, and it gets into the bloodstream, all right, what happens is 2 molecules of captopril will very quickly stick to one another. They stick together to form dimers, okay? And when they do that, they become inactive. So they are very rapidly deactivated upon administration because of the formation of dimers. They tend to dimerize or stick together, okay? And that was the major problem with this drug. The only way to overcome it was to increase the frequency of dosing. You're dosing it 2 or 3 times a day to keep your therapeutic levels where they need to be, okay? Everybody got that? That's why we don't use this drug very much anymore. And there's only one example in this class. Captopril is the only sulfhydryl containing ACE inhibitor. That's it. Okay? Everybody got it? And look, normally what I'm going to do, and I'll give you guys like a 3 or 4 minute break to run to the restroom, and I usually give you a good break, but we are kind of running a little short on time today. Okay? If you need to use the restroom or go get some caffeine, go ahead. Okay? You're not going to hurt my feelings or bother me or distract me. That's cool. Okay? At any point that you need to go. All right? All right. The next group is your dicarboxylic containing ACE inhibitors. Okay? Now, an example of this is enalapril. Now, I will tell you that one of the important features of this subclass of ACE inhibitors is that it's a prodrug. Everybody remember what prodrugs are? Yes. Right? They're drugs that, when administered, are inactive, and they have to undergo some sort of chemical modification or transformation, usually by some enzyme, to be converted to its active form. Okay? Now, if we take a look here, okay, here is enalapril. This is the prodrug form right here. Okay, this is inactive. It does not have any blood pressure lowering activity or ACE inhibiting activity. All right? Let's take a look and see if we can see the major features here. Okay? Here's our pyrrole ring, right, on the right side with our carboxylic acid group, right? Over here, okay, we have hydrocarbon chain, 2 methyl groups in our aromatic ring. So this is our first example of an ACE inhibitor with the 2 sides that we showed in the pharmacophore. Everybody following me? Now, where's the zinc binding group? Okay? The zinc binding group is this group right here, this carboxylic acid. See it right here? But notice that it's been esterified. An ester group has been attached to it. You see that right there? Okay? So we have our carboxylic acid group that is esterified. So that ester group sort of prevents this form of the drug from binding to the angiotensin converting enzyme. That's why it's inactive. Because its zinc binding group, which is right here, is shielded or blocked or covered by that ester group. Does that make sense? Yes, sir.
Was the drug developed like this, like for?
Yeah, go ahead. It was.
Okay, like because I don't know, for oral viability.
Exactly. That's exactly right. This drug was developed this way because when you esterify this zinc binding group, it significantly improves oral bioavailability. Okay? So what happens is you take this drug in the oral form, right? It gets through. It gets absorbed by the small intestines, and it's acted upon by liver esterases. And you can see right here what happens. The ester group is removed, and now you have a free carboxylic acid group there. This form of the drug can now bind to your angiotensin converting enzyme because the zinc binding group here has been uncovered. It's now exposed and free to bind to the zinc cation in your angiotensin converting enzyme. Prodrug, inactive. Why is it inactive? Because the zinc binding group here, which is this carboxyl group, is covered up by this ester functional group here. Okay? So it's not going to bind to that zinc cation. But when you take it orally, and that drug molecule, when this drug starts to get into the liver, right, after it's absorbed from the small intestines, it goes right to the liver. First pass metabolism, hepatic esterases remove that ester group right here, and now your carboxylic acid is uncovered and ready to bind to your ACE inhibitor. It's a prodrug. Okay? So again, if you're confused about that, the one thing you need to remember is it's a prodrug. Is captopril a prodrug, the one we just talked about? Nope, it is not. Okay? But all of your dicarboxyl containing ACE inhibitors are prodrugs. Okay? And they've got to be activated in the liver through the removal of this ester group here from the zinc binding group. All right? The last group of ACE inhibitors. We have our sulfhydryl containing ACE inhibitors. We have our dicarboxylic acid containing ACE inhibitors because they have a carboxyl group for a zinc binding group. And now we have our phosphorus containing ACE inhibitor. Okay? So guess what that zinc binding group is going to be? It's a phosphate group right here. Okay? Fosinapril. Phosphate, phos, right? Okay? So again, the same deal as before. Fosinapril and all the phosphorus containing ACE inhibitors are prodrugs. Okay? They're designed with their zinc binding groups covered up or shielded by an ester group. All right? This form of the drug, fosinapril, is inactive. Okay? But when it goes through the liver, after you take the oral form of it, it's converted by hepatic esterases to its active form called phosphinoprolact. Okay? And you can see, here's the phosphate group here. Is that ester group gone? Can you see it? Gone. So now this phosphate group is free to bind to that positively charged zinc cation. Go ahead, Dagmar.
So does the cinepril work the same way?
So in terms of lisinopril, yeah, same thing, same deal. It's a prodrug as well. It's converted to its active form, okay, by liver esterases, okay. All right. So one of the questions, a couple of things I could ask you here, okay. All right, on this, I want you to know which of these drugs are prodrugs, which class of drugs are prodrugs or not, okay. So we know our sulfhydryl-containing ACE inhibitors are not prodrugs. Everything else is. Captopril is your only non-ACE inhibitor prodrug. That's the easy way to remember. Okay? Got that? I want you to be able to identify the subclass of ACE inhibitor by looking at its chemical structure. How do you do that? Super easy. You look for the zinc binding group. There's only 3 kinds of them, right? All right? The way I always do this, if I give you a molecule like this on the exam without the name, and I ask you to tell me what subclass of ACE inhibitor is this? First thing you're going to do, okay, you're going to find the center of the molecule, okay? You're going to look for a sulfur. If there's a sulfur there, and it's a short molecule, it's captopril, it's a sulfhydryl, all right? If you don't see one there, you can eliminate that group, okay? The next one I look for is your phosphorus containing ACE inhibitors. Like, so I'll look for that phosphate group in the center of the molecule. If it's not there, what does it have to be? Dicarboxylic acid. For me, I don't know about you guys, but picking out the carboxyl group in this mess is a little tricky. You know, for some of it is. I look at it and I'm like, sometimes I have to look really hard to find it. But for me, looking for a sulfur or a phosphate group is easier for me. So I eliminate those 2 first. And if there's neither of those, then I know it's a dicarboxylic acid ACE inhibitor. Okay? All right? Everybody got it? All right, good. All right, so let's take a look at the cellular effects of these drugs. Okay, when we learn these drugs, these antihypertensive drugs, we're going to look at what they do at the cellular level or molecular level, which we've already talked about. You already know this. And how that translates into a change in organ function or tissue function, which we've already talked about. And then ultimately, how does that change our MAP equation? Okay, so anytime you're thinking about pharmacology of these drugs we're talking about, what's their cellular effects or molecular effects, right? Smallest level, what do they do at the smallest level? How does that translate into a change in organ or tissue function, right? And then how does that change your MAP equation? So let's start with our ACE inhibitors. Cellular effects, we've already talked about this. They block the angiotensin converting enzyme, okay? Which inhibits the conversion of angiotensin 1 to angiotensin 2. If you know your Raas cascade, this is a piece of cake. An additional effect of your ACE inhibitors that can lead to the cough side effect is that it also inhibits the breakdown of bradykinin, especially in the lungs. Okay? And in some people who are very sensitive to that, they can develop that cough, which may necessitate the switching to an ARB. Okay? And Dr. Naeem is going to talk all about that. All right? Everybody got that? That's the cellular effects. We've already talked about that. Okay? Now, again, this is just a different way of looking at what I just told you. Okay? Here's our Raas cascade. This is just a repeat. What do these drugs inhibit? Angiotensin converting enzyme. They also inhibit the breakdown of bradykinin. I don't even care that you know the kinase 2 enzyme. You don't need to know that. All you need to know is it inhibits the breakdown of bradykinin. And that builds up in the lungs and can cause cough. Okay? All right? Now, let's take this out a little bit here. if we inhibit the production of angiotensin II, what happens to aldosterone release from the adrenal gland? Does it go up or down? It goes down, right? Okay, it goes down. What happens to vasoconstriction if we reduce angiotensin II production? It goes down too, right? We actually get dilation of our blood vessels, right? Okay. What will that do to systemic vascular resistance? If we dilate our arteries, what does that do to SVR? It decreases it, right? And what does that do to blood pressure? It decreases it. Very good. All right. Let's take a look at aldosterone. We inhibit aldosterone secretion due to a reduction in angiotensin II levels in the body. What happens to sodium and water reabsorption? Does it go up or does it go down? It goes down, right? What happens to blood volume? Does it go up or go down? It goes down, right? That in turn, okay, will lower preload and venous return, okay, will reduce stroke volume and cardiac output, and that will lower blood pressure. I think I have a slide on that too. Yeah, right here. Here it is, right here. You got to know your math equation, folks, okay? You got to know this, because I will ask you about it and how these drugs impact it. So this summarizes it right here. All right? Blood pressure effects. MAP is equal to cardiac output times total peripheral resistance. Okay? There are three things that contribute to total peripheral resistance, if you remember from the video. Systemic vascular resistance, which is just an indicator of how constricted or relaxed your arteries are. Okay? SVR, all it is an indicator of how constricted or relaxed. If you have high SVR, systemic vascular resistance, are your blood vessels really constricted or are they super relaxed? They're really constricted. Very good. Okay? Other things, elasticity of your arteries, how supple and springy they are. Okay, yours are very supple and springy. Because I'm an old guy and I've had way too many Five Guys cheeseburgers, okay? Mine are very rigid, okay? And then viscosity, all right? How thick your blood is. So again, ACE inhibitors lower SVR by relaxing arteries. Everybody got that? You got to know that. Superstar it, whatever it takes. Down here, this is the tricky part, all right? All this is due to aldosterone, reduction in aldosterone levels and blood volume levels, okay? Which will reduce preload, the amount of blood in your ventricle before it contracts, okay? And that will reduce stroke volume, which is a part of cardiac output, all right? I also want to point out, too, SVR is the same thing as afterload. All right? I will use those terms. They're not 100% identical, but close enough that we're going to say that they're the same things. You don't need to worry about the differences between them. Okay? Afterload is essentially systemic vascular resistance. The higher the SVR, the higher the afterload. The lower the SVR, the lower the afterload. Okay? Systemic vascular, it's just two words for the same thing. Okay? Makes sense? So again, if we reduce afterload or SVR, that will also reduce preload and reduce stroke volume. Okay? That's another piece to it. So there are two things that are lowering stroke volume here, a reduction in afterload and a reduction in preload. Okay? So your ACE inhibitors work in this way. Okay? Again, if you're lost or you're confused, all I want you to understand right now is that ACE inhibitors reduce mean arterial pressure, okay, by reducing total peripheral resistance and by lowering cardiac output, okay? If you can understand that, then you can take it another layer down and understand why those things happen. And if you're having trouble with that, make an appointment, come and see me, or watch the recording on this, Okay? All right. I'm gonna keep going because I wanna make sure we get through this, all right? Actually, you know what? I need like 3 or 4 minutes. If you need to use the restroom, go ahead and run use the restroom. But I'll give you like the 2-minute warning in like a minute and a half, so, all right, go. And if you have questions, I'm here, all right?
So essentially,
Yeah.
it lowers everything.
Yeah. It lowers yeah, absolutely, by lowering cardiac output. Systemic output. Now, there are other drugs that will do the same thing. Like, for example, beta blockers. And we're going to talk about them. The beta blockers lower both cardiac output and systemic output. And they do it by blocking heart rate, stroke volume, by causing vasodilation, reducing renin release from the kidneys, and they do, they have an expansive effect. But yeah, when you look at the MAP equation, very basically, some drugs will lower TPR by themselves, some will just lower cardiac output by themselves, and others do both. Okay? And does that necessarily make them better drugs or more clinically useful? Do they have better clinical outcomes? No. It's just how they work. Who's that? What's that? Really?
Like there's a risk of getting worse.
Really? I haven't heard that. I'm gonna have to talk to Dr. Naeem because I'll take that off the slides.
I'm not sure, but
So I appreciate what she said. Yeah, I'm gonna have to take a look at that and see. That's really interesting, and that's a shame too because cardiology has been used for years. It has some pretty good outcomes. It sounds like they might be finding some other things that might prevent its usage.
because she was asking me the receptors
Yeah, interesting. Yeah, for heart failure, right?
Yeah.
I'm gonna have to talk to Dr. Naeem and see what because but I don't necessarily follow that.
Or I think it's just the institution.
Okay, yeah, interesting. Okay, cool. All right, 2-minute warning. 2-minute warning. I haven't talked to okay, so I'll let you know.
Yeah, I know.
¿Qué pasó?
Yo chequeé ahora
All right, let's get started again. All right. Okay. So, again, just to recap, if you are struggling with this right here, okay, and that's perfectly normal, okay. Even when I used to spend 2 hours teaching blood pressure regulation on day one, we don't do it anymore because we don't have time. People would still be confused about this. It does take a little bit of time to get, used to this and understand it. But if you haven't watched the video, you're probably going to be lost here, okay, or the recorded lecture. So make sure you do that tonight. Don't hesitate to ask me questions if you've got them outside of class, schedule an appointment, okay, because I want to get you straightened out on all of this, all right? I want to go back to this just very quickly before we move on to our angiotensin receptor blockers and give you some good news, okay? If you understand how ACE inhibitors do all this up here, okay, guess what? Your ARBs do the same thing. You don't have to learn it again. Your direct reading inhibitors do the same thing as this. They all do the same thing at the tissue body level, or at the body level, the blood pressure regulating level. All right? They just have different cellular effects. Okay? Does that make sense? All right? So once you get this down for ACE inhibitors, same thing for your ARBs, same thing for your direct reading inhibitors. Okay? Take out, go ahead.
So, in a nutshell, we're trying to avoid constriction, right?
So in a nutshell, a lot of our drugs, right, they work to lower blood pressure by relaxing arteries, right? Because we can do that and reduce systemic vascular resistance or afterload, same thing, okay? That itself will reduce total peripheral resistance and you get a reduction in blood pressure. Think about the hose example again, right? You got a hose with no good hose head on it. It's just blank at the top. And water's kind of spilling out. You can't squirt anybody, right? You put your thumb over that, you get a nice stream of water, you can squirt your friend, your parents, or your whatever, brother or sister that's annoying you. But as soon as you take your thumb off of it, what happens to the water pressure? It goes right down again, right? It's just like what we were doing with ACE inhibitors. We relax our blood vessels, and we lower that resistance to blood flow, and that will lower blood pressure, okay? The other effect that's super important here is reducing cardiac output. If you remember, cardiac output is the amount of blood pumped by the heart per minute, okay? Right? Cardiac output, the amount of blood pumped by the heart per minute. And there are two things that determine whether cardiac output is high or low. And that's heart rate, right? Which is how fast your heart's beating, and stroke volume. How forcefully your heart's contracting, right? If any of you were a plumber in your previous life, okay, that's all the circulatory system is. It's a pump with tubes attached to it. The difference is between your bathroom plumbing and this are that these tubes can increase their diameter or shrink their diameter through relaxation or constriction. So it's more of a dynamic system, but the principles are all the same thing. Okay? Everybody got it? All right? All right. So let's talk about your angiotensin receptor blockers. Okay? These are a newer class of agents than your ACE inhibitors, but they've been around for decades. Okay? I remember when these first came out 30 years ago when I started teaching them. And everybody was really excited about them. And, you know, we've had decades of experience with them. We know that they're super effective in treating hypertension, reducing morbidity and mortality associated with hypertension. The cost has come down dramatically over the last 3 decades. They used to be super duper expensive, right? But now, you know, the generic forms and things like that. So, again, they're very, very useful agents. One of them is losartan. This is the one drug I'll use. This is kind of the original angiotensin receptor blocker. Okay. Valsartan is another one, so it's your sartans, right? Just like with your ACE inhibitors, you have your prils, right? Okay. Fosinapril, captopril, enalapril, lisinopril, right? All your prils are ACE inhibitors. Your artans are your ARBs. Okay. All right, so again, the bioavailability of your angiotensin receptor blockers aren't as great as some of your other classes of drugs, yet they are very, very effective. And I think one of the things that I want to point out, all right, this is the chemical structure of losartan right here, first of all. I don't have any structure-activity relationships for you, so don't worry about that. You don't need to know anything about the structure. You don't have to identify it. There's no functional groups on there that I want you to know, okay? But what I do want you to know, okay, is that losartan, as it's metabolized by the body, and it's not a prodrug. Losartan is active in this form, okay? But like every other drug in the body, it is metabolized by cytochrome P450 enzymes. And what we see here is that a byproduct of the metabolism of losartan is an active carboxylic acid metabolite right here. That happens a lot of times with drugs. You'll have an active drug that's administered to the body, it starts to get chemically modified, and one of the metabolites may also have pharmacological activity. Okay? And this is the case. Most of the time, when the drugs are metabolized, they're broken down into inactive forms, but sometimes in that process, you get an active metabolite in this form. This is a great example of it, okay? This active carboxylic acid metabolite actually contributes to the blood pressure lowering effects of losartan. So the parent drug and the metabolite here work together to block angiotensin receptors, okay? Everybody got that? Do I want you to know the cytochrome P450 enzymes? No. Do I want you to be able to identify the active carboxylic acid metabolite? No. All I want you to remember is that through the metabolic process of losartan, a pharmacologically active metabolite is produced that contributes to the blood pressure lowering effects of the drug. You guys can remember that and understand that, okay? Good. That's all I want you to know. Okay? Good? All right. Question? Yes, Kingsley, go ahead.
So we did account for longer acting activity of the drug, or would it account for increased activity?
That's a really good question. So what you're saying is if we compare the effects of losartan by itself, we can do that. On the effects compared to the combined effects of these two, okay, you'd probably see a more prolonged effect that contributes to, because this, as we're going to find out here in a second, this metabolite binds almost irreversibly to the angiotensin receptor itself. But it's produced in such low amounts You know what I'm saying? So I would say theoretically speaking, it might prolong the effects, but you would never be tested on it, you'll never hear a clinician talking about it. It would be kind of a fun theoretical discussion for us to have, like, hey, what would be the impact of this? Yeah, there could be some pharmacogenomics, but I've never heard of that from a clinical standpoint. That's something else I want you guys to understand too, all right? There's a lot of folks like myself, okay, that will teach you the pharmacology of the drugs. And there's some interesting things here to talk about. But and Kingsley brought up a good point. Well, is there a potential pharmacogenomic issue here? Let's say someone doesn't possess or have an active CYP3A4 enzyme, right? Would that affect the activity of losartan in that patient? No. Okay? Not that I'm aware of. I've never heard a clinician talk about a pharmacokinetic interaction here. Or, hey, if you have a patient with a CYP3A4 deficiency, or they're taking another drug metabolized by CYP3A4, don't give them losartan. Never heard that ever. All right? And I don't think that's the case. I think you can give it to anybody and not worry about it. Because, again, it's just a small part, like 14% of the oral dose is converted to this active metabolite. Okay? But it is a unique feature of it. Okay? All right. Whether we're talking about the parent drug losartan, or whether we're talking about the 5-carboxylic acid metabolite, both of these molecules bind and block the angiotensin receptor. Okay? That's why we call them angiotensin receptor blockers, right? ARBs, because they block the angiotensin receptor. All right? The only difference is how they do it. Okay? The parent drug is an equilibrium competitive antagonist. Remember that from basic pharmacology, right? 2 years ago, right? Okay? All that means, that fancy word, is that the parent drug binds reversibly. It sticks to the receptor and blocks it, and then it comes off. Okay? What makes the 5-carboxylic acid metabolites unique is that it acts like a non-equilibrium competitive antagonist. When it binds to the angiotensin receptor, it binds almost irreversibly. It'll come off the receptor, but it takes a long, long time. So it's really interesting, right? We have a drug that has two chemical forms, parent form and a carboxylic acid metabolite, very similar to one another, just the addition of that carboxyl group. One binds reversibly to the receptor, the other one binds almost irreversibly. But they both target the same receptor, and they both contribute to the overall effect of the drug. Okay? You will never have a conversation as a clinical pharmacist with anybody about the 5-carboxylic acid metabolite of the drug. Okay? In fact, I could probably get rid of that, and it would have zero impact on your ability to be a pharmacist. Okay? And maybe I should, but I'm kind of indulging myself a little bit here, just so you know a little bit more. Okay? All right? Yes, sir.
With this class of drugs, there is the hypertension side effect. So I was going to ask, could it be that triggers the hypertension?
Hypotension?
Yeah, hypertension.
Yeah, high blood pressure?
Yeah.
Yeah, no, I think it just could be due to the overall sensitivity that a patient would have to the dose that you're getting. Okay? With any of your and that's a great point too. With any of your antihypertensive medications, could you potentially get too low of blood pressure? Could you get hypotensive? Sure you could. A lot of that depends on the patient's sensitivity to the drug, how much you're giving, or if they're already on another antihypertensive agent and you're adding an additional one to get their blood pressure low. Does that make sense? So you always kind of watch out for that. All right? Here's our Raas cascade again. All right? This is where your angiotensin receptor blockers work. There they are right there. There are your ARBs. You can write an ARBS if you want to. ARBs right here. They prevent angiotensin 2 from causing vasoconstriction and aldosterone release by blocking its receptors. They are antagonists, like we talked about 2 years ago. Okay? Will your ARBs cause cough? No, because they don't have any effect over here, do they? Okay? Could they cause hyperkalemia? Could they cause hyperkalemia?
Yes.
Yes, they can, okay? Make me proud when Dr. Naeem talks about this, all right? Because you got to monitor for that, all right? All right, because I don't want her to think I'm slacking off here, all right? On a whole body level, how do they reduce blood pressure? The same way your ACE inhibitors do. They reduce systemic vascular resistance. They let your arteries relax, right? And when your arteries relax, SVR goes down, afterload goes down. It makes it easier for your heart to pump blood through the blood vessels, and it reduces blood pressure, okay? It also reduces stroke volume in the same way, okay? ARBs inhibit aldosterone release, just like ACE inhibitors do. They just do it a little differently, right? When we inhibit aldosterone, we reduce blood volume, which will reduce preload, the amount of blood in the left ventricle prior to contraction. Okay? If we reduce preload, we reduce stroke volume. Okay? All right. If we reduce afterload or SVR, that also contributes to a reduction in stroke volume, the amount of blood ejected from the left ventricle every time it contracts. All right? So again, if you know one, you know them all. Everybody got that? Who's got questions about this? I'm seeing it's the 405, face. I'll call it the 405 face, right? All right? Which I'll see a lot of this semester. And it's okay, I get it. It's day one. Your brain is now, it was shot 20 minutes ago, I know, right? Because you're still on summer break, right? You haven't had to use your brain for a while, I get it. What questions do you have? What do you want me to re-explain? And trust me, if you want me to re-explain something, I guarantee you there's 10 or 15 other people in this room that want it re-explained to you, they're just too afraid to ask. And I get that, it's okay. Is there anything you want me to re-explain? Go ahead.
So we were trying to figure out why does losartan has potassium?
Why does it have potassium in it?
Yeah, like the salt formulation, losartan, potassium.
Boy, you know what? That's really interesting. So a couple of things. It may be that the potassium salt form of losartan is the only salt they could make to make it. Yeah, exactly. And it's soluble in an aqueous environment, right? I would imagine the amount of potassium that's in that is very small. It's very small. So these guys were asking about the potassium that is part of the formulation of the losartan to make it a salt form, right? Which increases solubility and absorption, right? And again, does that make a lot of sense with the hyperkalemic effects of the drug? There's, again, I think the amount of potassium that's available, that's in the formulation, very, very minimal. So, it will have minimal, if any, effects on plasma potassium levels. But it's an interesting question, and I like the way that you're thinking. All right. What else? Yes, sir.
So I'm trying to understand what does the prefix Brady? I know Brady is like, or Brady.
Brady, right?
Brady points towards lowering.
Yep.
So in the context of Brady, can you break down that word?
Yeah. So Brady, you're absolutely right. Like Brady cardia, right? Low heart rate. So in the case of bradykinin, okay. My guess is, and I don't know for sure because no one's ever asked me that question. It's a good question, but again, what I would imagine it means is lower blood pressure. Because that's what it does. Bradykinin lowers blood pressure by causing vasodilation. So that Brady in that case may be referred to lowering resistance, lowering blood pressure. Okay, that's my guess. Okay, you guys find out something different from me now. All right. What other questions do we have? We good? Good? Sure? So far? I think I need to sit down. You know if I sit down over here? All right. Everybody can hear me all right?
Yeah.
All right, I'm just going to sit down because I'm tired. I'm old. I'm tired. Okay. All right. Last class of drugs. You guys are almost there. We're doing great today. Yeah.
And you say synogen.
Yeah.
kinase of them, do they come from the same organ in the body?
They come from the liver, yes.
Both of them are.
I believe so, yes. Okay? All right, allostyrin. So these are your direct renin inhibitors. So I got some great news for you, okay? If I had to eliminate one group of drugs from this lecture, it would be your direct renin inhibitors. You know why? Because we don't use them. How many people work in a community pharmacy? How many people have ever seen allostyrin dispensed? Allostyrin? No? You know why? 2 reasons. It's not on the market, it's expensive, and it doesn't work any better than anything else. So it may not even be on the market anymore. Dr. Naeem didn't say anything to me, but these are direct renin inhibitors. They're one of those drugs that they developed and it's like, well, okay. You know, they were bored, somebody wanted to come up with a new, antihypertensive medication, but it turns out it's expensive and it doesn't work any better than any of the other drugs.
Is this older or newer?
It is the newest of these 3 classes of drugs. In fact, I remember when it came out, and I'm going to guess because I'm a little hazy, about 15 years ago when it came out, I was so excited. All right, I was like, this is the first new antihypertensive drug that's come out in like decades, right? So I had something new to teach, and I was really excited. And I remember I was teaching it the first year. I got really excited, was getting into it, and Dr. Holman, who's no longer here, she was a clinician that I used to teach with. And I said, well, what do you think, Dr. Holman? She's like, well, I got some bad news, Dr. Holman. We're not ever going to use this because there's no, the clinical data is no better, it's expensive, and it doesn't work any better than any of the other drugs. And I'm like, okay, thanks for telling me. All right, but I got excited at least by that. But at any rate, I'm just going to tell you what basics about this. The way this drug works is it inhibits renin, hence its name, a direct renin inhibitor. Okay. I don't even care that it's a competitive antagonist. I don't even care about that, all right? Because it inhibits renin, it inhibits the conversion of angiotensinogen to angiotensin. So it works at the top of the cascade, right at the top, okay? There it is right there, okay? All right, will this cause cough?
No.
Nope, it will not. Can it cause hyperkalemia? Yes, it can. They all do. Okay? All right? How does it lower blood pressure? The same way. It's kind of boring after a while, right? Boring is good in this module, trust me. Okay? Anybody want me to go over this? I'm sorry I'm being lazy. You guys are very patient. I appreciate your patience. All right. All right, let's take a look at this mess here. Okay? This kind of summarizes everything we just talked about. All right? Do you need to understand this to really get the gist of what we talked about? No. But if you're trying to put everything together, all right, if you understand this, that means you got a good understanding of everything we've talked about, because this is all 3 classes of drugs on here and how they work. All right? Let's just go over here to the right. See, we have our renin here and our ACE enzyme here. Again, we have drugs that will block it. Your direct renin inhibitors and your ACE inhibitors. See that down there? Okay? Your ARBs block your angiotensin receptors, AT1 receptors. Okay? And all of that, again, your renin, your direct renin inhibitors and your ACE inhibitors, all they do is they reduce angiotensin II production. Your ARBs block angiotensin II at its receptors. So a little bit different in terms of the cellular effects, but overall, everything else is the same. You get a reduction in SVR and afterload, okay? You get a reduction in aldosterone release, a decrease in blood volume, okay? A decrease in preload and a decrease in stroke volume. And that will decrease cardiac output. This is what I wanted to try to get across here, is that even though they all have slightly different targets and do different things, their overall effects on blood pressure essentially the same. So if you know how one works, All you have to really do is know where the other one works. Does it work on the ACE enzyme? Does it work on the renin enzyme? Or does it block the receptor? Okay? That's it. Okay? So it's not that hard. All right? All right. Yes, sir.
Okay, if we take away the price factor,
Yep.
is there any advantage of using a direct renin blocker?
No. In fact, we don't have a lot of clinical data on them because nobody ever really uses it. There hasn't been a lot of big studies. Okay? That's why, Kingsley, of all three of these classes, what are your two big classes out of here that you're going to see used all the time? ACEs and ARBs, right? Why? Because there's been a ton of clinical data generated to show that not only are they effective at lowering blood pressure, but more importantly, they reduce the morbidity and mortality associated with hypertension. Okay? And that's the reason we use them. Okay? They're inexpensive. All right? ACEs and ARBs now are really cheap, right? We've got forms that are dosed, very infrequently, once a day, right? Maybe twice a day, once a day, right? We know how they work. We're comfortable with them. And we know that they do the things we need them to do. That's why they're first-line agents, okay? For most populations of patients, okay? If you've got a patient that comes into your pharmacy and has their first prescription because they were just diagnosed with high blood pressure, okay? 9 times out of 10, it's going to be for an ACE inhibitor or some type of calcium channel blocker or thiazide-like diuretic. Thiazide-like diuretic. If it's something else, if it's something else, scratch your head a little bit. There might be a weird reason why they're on something else, but for the vast majority of people, that's what they get started on. And if it controls their blood pressure, great. If it doesn't, guess what you do next? You increase the dose, right? Until you get to a max dose, right? And if it's still not controlled, what do? You add on another drug, right? And you start at the bottom, bottom dose. You start titrating that up, right? And if that doesn't get the blood pressure to goal, what do? You add on another one, right? So you see how you need to be thinking with this, right? And for some people, like if I was diagnosed with hypertension, I don't have any other comorbid conditions that would, so again, if my doctor's sitting there like, okay, so what do you want to go on? Right? You want to be on an ACE inhibitor, or do you want to be on a calcium channel blocker? Do you want to be on a thiazide diuretic? You can pick one. Okay? With other people with other comorbid conditions or other special considerations, which Dr. Naeem will tell you about, you might choose one of those first-line agents over another. It just depends. That's what you have to learn. Okay? Right? But if you get it, it's not hard. All right? If you understand the thought process behind it. All right. I shouldn't be saying that because Dr. Naeem is going to do an awesome job of teaching you all of that. All right. So a couple of things here. Renal effects of RAS inhibition. So the information on this slide pertains or applies to all the drugs that we just talked about. Okay? And we've already discussed this. Renal effects. Okay? So your ACE inhibitors have an effect on electrolyte management by the kidneys because they all inhibit aldosterone release. So if you know how aldosterone works, all you got to do is reverse that when you talk about a drug that inhibits it, right? So, retention of potassium, which can lead to hyperkalemia. It may not, but it's going to be something that you're going to monitor and keep an eye on, right? All of these drugs have the potential of causing hyperkalemia because of their inhibition of aldosterone, okay? They all will cause sodium loss, right? Because remember, aldosterone stimulates sodium and water reabsorption and potassium loss. That's what aldosterone does. And when we block it, just the opposite happens. Your body holds on to potassium and gets rid of sodium. Everybody got that? That's why I like this, right? Because if you understand that, and it's easy for me to say because I've been teaching this for 30 years, okay? I get it. But once you get it, it's like, oh yeah, that makes sense. You don't have to guess. You don't have to memorize stuff you don't understand how it works. You understand how the system works. this stuff makes a ton of sense. Okay? I'm not the sharpest tool in the shed, but I get this because it makes sense. Okay? All right, renal protection. These agents, especially your ACEs and ARBs, we refer to them as being renal protective. They protect the kidneys from damage due to high blood pressure. Okay? And you're going to talk a lot about ACEs and ARBs in the renal module. All right? They're going to talk to you about that. These are really good drugs to protect kidneys, especially in hypertensive patients or patients that already have pre-existing renal disease. Okay? And they do that, okay, because your ACEs and ARBs have a very special effect on one of the arterioles that are connected with the glomerulus. What they do is they dilate the renal, okay, efferent arteriole, okay? And I'll show you this picture here in the next, and that reduces glomerular hydrostatic pressure. I'm going to show you this in the next 3 slides here, okay? All right, so now this is not easy, and I hate to do this right at the end of class because I know where you're at. Okay, so I need you to dig deep, okay? I need you to dig deep right now to those mental reserves. I need you to sit up straight. I need you to pretend that you're awake, and I need you to focus for the next 10 minutes, okay? Please. I know it's a long day. You can do this for me. All right? Everybody look at the top cartoon picture. All right? This is a picture of part of the renal nephron. I haven't learned about that since biomed, right? Okay? Been a while. This is the very beginning of the renal nephron here. This is your Bowman's capsule, right? Okay? With your glomerulus on the inside. All right? And this is the proximal convoluted tubule, that first part of the nephron. Everybody remember that? Okay? Now, and there's millions of these in your kidneys. The problem is that when one gets damaged, it doesn't get repaired. So, again, protecting your kidneys from very high or very low blood pressure is super important because your kidney does not repair itself. Okay? Right? Just like your brain cells, your neurons, they don't reproduce, right? So as you know, if you're like me after half a century of life, right? I've lost some brain cells over time, okay? I'm definitely not as sharp as I was when I was your age, but I'm still sharp enough, okay? All right, so let's take a look here. I want you to pretend and think of the glomerulus like a balloon, okay? Everybody's played with a balloon before, right? You've had them at your birthday parties or whatever, right? What happens when you blow too much air into a balloon? It pops, right? What happens if you let all the air out of the balloon that's inflated? It collapses, okay? Neither are good. So if you think of your glomerulus like a balloon, okay, because it's like that, only it's got blood in it instead of air, okay? Too much blood in the glomerulus can cause it to what? Pop. And if it does, that nephron is dead, okay? Too little will cause that glomerulus to collapse and can cause it to be irreversibly damaged as well. Your kidneys do not do well under circumstances where your blood pressure is super high or low because of this reason. So your body works really, really hard to maintain your blood pressure, all right, in a certain range. Okay? If you've got somebody that comes into the emergency room with a systolic blood pressure over 190, right, or diastolic blood pressure, in the hundreds, okay, one of the first things they're going to be concerned about is kidney function. That's one of the things because some of those glomeruli might be popping, right? Or if you're hypertensive because you're in shock, okay, they want to protect those kidneys, all right? Get you get some volume back into your circulatory system. Get a vasoconstrictor on board so you get your blood pressure up to protect your kidneys, okay? Now, under normal circumstances, let's go back to the anatomy here. You guys remember you've got two. Yes, go ahead, Jess.
Wait, Okay, you said 10 more minutes. I just want to let you know we're out of class at 4:20. But if you would like to.
Oh, you're right. You're right. I forgot. It's 3:30 to 4:20. Thank you for letting me know. Guess what? Let's give Jess a round of applause because she just saved you from this mess. I appreciate that. It'll take me a little bit of time to get used to the schedule. So again, don't be afraid to let me know when it's break time. We always break after an hour and the end of class. What we'll do tomorrow is we're going to start off with this when you're fresher, and then we're going to talk about how to do it. All right? Good stuff. Great job today. Good work. Okay, have a good evening. Catch you tomorrow.
Just a couple questions.
Jess is the hero today. Thank you, Jess.
Dr. Cohen would have kept.
My 5 neurons, Dr. Colleen would have kept going. My 5 neurons that are still functioning are flagging a little bit. So thank you.
Thank you.